remember we took the slides when it was stained, it looked like this. So now this allows us to look at it under the microscope with a color change. Yeah, so when I look at it under the microscope, I'm able to see, and actually what I'm seeing under the microscope is exactly what is projecting on the screen there. So this is actually a fibroid, and by looking under the screen, I'm able to see the cells, the pattern of the cells and the shape of the cells to say that this is a smooth muscle tumor. But there are certain things I'm not seeing, and I'm able to say this is not cancerous, but it is benign, yes, by looking at it. For screening, we mainly use pap smear. And in this case, we are taking the sample from the cervix to see, are the cells starting to misbehave? Are they starting to change before they become malignant? Almost like, are these students becoming rowdy or unsettled before they go onto the streets? So you're looking for changes pre-malignant and you're screening. But then there is even newer technology nowadays, what we call molecular pathology. And in this case, we're able to test the DNA of the cells and look for viruses, for example, that cause cancer, like human papilloma virus. So in this case, we don't use a microscope, but we use specialized equipment to look at the changes in the cell, whether the viruses have gone into the cell, viruses that cause the cancer. That is called PCR. We use this for the HPV, human papilloma virus. In fact, this allows a woman to even take a self-sample. So you don't have to go to the doctor, you can collect the sample, and then we are looking for high-risk HPV virus that is responsible for causing cervical cancer. So this new technology, we don't need the pathologist to look under the microscope. With the sample, the machine is able to tell us this is high-risk HPV, and when you have high-risk HPV, now we go ahead and do a pap smear or a biopsy. So not everybody needs a pap smear because it can be quite uncomfortable, yeah. So on the same, we can also use it for doing other viruses like hepatitis C, hepatitis B, HIV, TB, and the rest. This one, you're able to do specialized stains with specific antibodies to be able to determine like the subtype of cancer, like lymphoma. Once I see the H&E, I'm able to say this is lymphoma, but with this one, I'm able to say, is it a B-cell lymphoma, T-cell lymphoma, using certain antibodies. So the slides go in here. Once they've been stained, it looks something like this, you know? Yeah, brownish, yeah. But now it's specific targeted antibodies. Like you can say, is this breast cancer estrogen receptor positive or negative, things like that, yes.
Okay. Because you're talking about the pathologist looking under a microscope to make a diagnosis, are there instances where a misdiagnosis or a wrong diagnosis is made?
Yes, it can happen, and it does happen. And when it happens, it can have severe consequences in terms of the outcome for that patient. Either an incorrect diagnosis or somebody being told they have cancer and they didn't have the cancer, or a situation where somebody is told you don't have cancer and you actually have cancer. Just like policemen who are trying to establish whether certain people are thugs or they are innocent. You know, they might end up shooting somebody just because he has dreadlocks and he looked rowdy, but Kube is the Rastafari, not a Mungiki, for example. Yeah, you can actually make a mistake, and that's why, for example, for policemen, before the policemen who get involved in extrajudicial killing, usually they're not very well trained or they act in haste. But very well trained detectives are able to look for all the proper signs to be able to make a diagnosis before they shoot, for example. So we as pathologists, we spend years of training, and that's why pathology is a specialized field. We spend years to look at all those changes so that we can try as much as possible to narrow down in making the right diagnosis and avoiding making the wrong diagnosis. Those are two different things. Because if you fail to diagnose something as cancer and yet it is cancer, that person might end up dying because of that misdiagnosis. On the other hand, if you say somebody has cancer when they don't have cancer, they might end up getting treatment when they didn't need it, and those treatments usually, most of the time, they're harmful to the body, they're toxic. So if you give somebody chemotherapy or radiotherapy on a breast cancer, for example, and there was no cancer in that particular case, you're actually harming them. So the first principle in medicine is do no harm.
The lab report should be able to tell you whether this to guide you whether this is a quality lab report or not. One of the things is ideally all laboratory tests should be signed or countersigned by a pathologist who is licensed to practice in the country. Yes, and then also the technology also countersigns. That's one of the things. And again, for our clinicians, when they read through a report, even the format the report has been given in, can be able to tell this is a quality report or this is basically a quack report. You need to confirm whether the people who are working there are really people who are qualified and certified by their associations. As pathologists, we are basically certified practice by the Kenya Medical Practitioner and Ethics Board. Then under us, we also have technologists who work under us, and they are certified by the Kenya Medical Laboratory Technologies and Technicians Board. So all that needs to be displayed. So, and one of the easiest things is ideally everyone who is working in a lab should be in a dust coat, a white coat, dressed neatly, and they should have a name tag showing their name and their basically their qualification, their pathologists, whether there's a lab technologist, and so that. Then the other thing you can look for is to see whether that laboratory is accredited. We have international bodies and also national bodies which accredit laboratories. In Kenya, KENAS, Kenya National KENAS Accreditation Services. Kenya National Accreditation Services is one of the bodies which actually has been accrediting labs. Internationally, we have South African, American, and many other bodies which can accredit labs, and that's is a show of quality that these are quality lab which can give quality results.
What could lead to pathologists making this kind of errors?
Yeah, things like training, support, technical equipment, personnel. So most of the time, errors in the laboratory can happen because of things like mixing up of tissues. You know, a biopsy was taken in the lab, a biopsy was taken in the theater, and when the biopsy was taken in the theater, the sample got mixed up. Yeah, Mercy's sample was mixed with Irene's sample, for example, and Mercy might not have cancer and Irene has cancer, and when that sample gets to the lab, you get the wrong diagnosis. That's why you spend a lot of time making sure that all the processes in the lab are as foolproof as possible. So what we call clerical or human errors, pre-analytical errors. The samples will be brought by our couriers or messengers from the courier delivery company. And when they come, they typically will come in a container like this, in a cooler box, or in small boxes. Now, I think this one has a fluid sample. Yeah, it also has a tissue biopsy. And normally what will happen is that she will receive the samples, barcode them, and then once she barcodes them, checks all the details. You know, she has to double check the details on the form and the number so that there is no mix-up. Remember I told you mix-up is, actually studies have shown 90% of errors in the lab happen before the lab. Mix-up if the tissue is not adequate, if the sample is not well, thank you, Sen. Yeah, so even how the sample is prepared. For example, if you look at this container, it has a thermometer. This thermometer is a digital thermometer to monitor the temperature of the sample. Because, for example, if it is fluid or blood, if it is overcooked because of heat, it can affect. So you'll find that inside here there is even ice packs. Yeah? There are these ice packs to keep it cool and maintain the temperature. So these are the things that she'll check. And then once she has checked, she does what we call, she receives it, puts it in that packet, and then now it will go to the next step. Now in the next step is what we call accessioning. The accessioning means the details of the patient will be entered on the system. Now in our scenario, once it's entered, then we become paperless. The papers stop here, the rest of the lab is paperless. So this is the station where they will receive the details. The doctor's details will be entered on the system, the email address, and so on and so forth, because after this, the results will go according to what is on the request form and what is on the details there. But in the laboratory, errors can happen because of the way the tissue is handled. If it's not stained properly, it can end up looking different, simply because of the way it was stained. And in that case, then the pathologist might be competent, but the technologist who worked on the tissue did not do a good job, and it misleads the pathologist. But also, the pathologist can also make a mistake, simply either because of inexperience, lack of knowledge, because you can't diagnose what you don't know. You know, so you really need to look under the microscope and having been well trained and know it properly to be able to make that diagnosis. So all these are areas where errors can happen. Lastly, an error can happen because when a pathologist makes a diagnosis, it has to be communicated to a doctor. That one we communicate in the form of a report, and it's typed. Now, you can, for example, say there is no evidence of this, but somebody misses to put the no. So it goes, there is no, instead of saying there is no evidence of malignancy, it goes, there is evidence of malignancy or evidence of breast cancer. So what we call transcription errors or post-analytical. So all these are areas where errors can occur. Yes.
Can we possibly do without a laboratory diagnosis by a pathologist for cancers?
For cancer, you can't do without a pathologist. No cancer can be diagnosed conclusively or fully without a pathological diagnosis. And the reason is because certain diseases can mimic cancer. They can look like cancer. Somebody can have what looks like a brain tumor, but when a biopsy is taken, it turns out to be tuberculosis. Somebody can have a lump maybe on their shoulder, and it might look like fat, just normal fat, or what we call lipoma, grown fat. But that is benign. It's not cancerous. It's not malignant. But once you take the biopsy, then you find, oops, it's actually malignant. And if you didn't take a biopsy, if you do look at it under the microscope, you might call it benign. That is, it's not malignant. And then after some 2 years, the person has cancer spread because of that. So for cancer, by and large, you can't do without a biopsy confirmation because other diseases, including infections like TB, can mimic cancer.
One of the things we stress to our medical students and even the young doctors is don't request for a test which will not assist you in managing the patient. And we also emphasize that our young doctors to know that every test we ask for, there's a cost implication, and don't put an extra financial burden on the patient. So that's something we always keenly look at. And if we now close for cancer care, most of the big established hospitals, we have what we call tumor boards. So in a tumor board, you find is basically a meeting of experts, doctor experts, study all the way from the clinician, the medical officers, even students, pathologists, physicians, surgeons, the oncologists, whereby we meet and discuss a certain cancer patient. How from the time they presented, how the diagnosis was made, and how they are being managed. And during some of those meetings is where we pick out some of these things and educate our young doctors that you don't necessarily need to ask for this panel of tests. You can ask this test, this, and it will be enough, rather than asking just a whole battery of tests. But over and above, most doctors request for the required number of tests.
Now, for other diseases like microbiology, chemical pathology, yeah, you can do without a pathologist in particular settings where the results are normal. But if the results are abnormal, then you need a pathologist to interpret so that a conclusive diagnosis can be given. So pathologists are key, although they work behind the scenes. Just like I always tell people, pathologists are almost like civil engineers or engineers in general. You only see the architect, but you don't see the engineers. Yet the building cannot happen. This building will not have been put up without a civil engineer or a mechanical engineer. So the civil engineer is like a pathologist. They work behind the scenes. But buildings cannot happen or cannot be built without engineers. Yeah. Not all lumps and swellings are cancer. And not all cancers present with lumps and swellings. So somebody can have a lump, but it could be what we call benign. Or it could even just be, for example, if a child fell somewhere, they bleed under the skin, what we call a hematoma. So I can fall or something can hit me and I get a hematoma, swelling on my face. And somebody might worry, this looks cancerous. But then when you go for X-ray or CT scan, they might say, oh, this looks like blood. But if they're able to associate that with maybe trauma, they can say this is most likely blood. But if it doesn't resolve after some time, then a fine needle aspiration or biopsy to take a sample will be required. So not everything that is a lump is necessarily cancerous. We also have sometimes abnormal growth of tissue, but it is not cancerous. In other words, it won't kill the person. For example, fat on the head, like you remember the famous case of Mutai, what was his name? Wahome Mutai, the famous case of Wahome Mutai, the whispers, yes. He had a lump on the scalp, but it was actually fat. Unfortunately, when he went for the biopsy, he had a complication in surgery. But in that case, it was not cancerous, but it was being removed because of cosmetic reasons or concerns that it could be cancer. Previously, for diagnosis, we had to remove the tissue. But nowadays, technology has advanced. We're able to take small pieces of it using what we call core biopsy. So somebody doesn't need to go to theater. Just with what we call a biopsy gun, we can take a small piece of tissue before somebody goes to theater. For example, thyroid swelling, it's not necessarily cancerous. You can go for an ultrasound, a fine needle aspiration. We take some samples from it. We can say this most likely cancerous or is most likely benign. If it's most likely benign, then you go to theater and it's removed. If it's most likely cancerous, certain things have to be done. So the point is not all swelling are cancerous, but if somebody has a swelling anywhere in the body, they have to go and be checked. But I must emphasize this. Majority of cancers don't present with swellings. Majority of cancers are hidden. Like, for example, cancer of the cervix. Nobody feels the cervix or not the prostate in men. By the time actually the person gets blood coming off their urine or a woman getting a lot of heavy bleeding or pain, it means the cancer has actually really progressed. So not all cancers present with swellings, and if they present with swellings, these swellings are actually hidden. For example, if you have cancer of the bowel in the large intestine or the stomach, for example, usually in that kind of scenario, yes, there will be a swelling, but it won't be visible. By the time you start feeling a swelling, or let's say kidney tumor, you start feeling a swelling, it means it's really progressed. And that's why if somebody is feeling unwell, if somebody has maybe certain changes in their body, it's good to go and be checked, because usually the doctors ask themselves, could it be cancer? But then there are certain cancers that are almost even impossible to examine and diagnose unless you do certain tests. Like, for example, prostate cancer, before you actually feel the prostate, it means it's quite progressed. So we do what we call PSA, prostatic specific antigen, which is a special chemical that we test in the lab to look at the risk or likelihood of prostate cancer. For prostate specific antigen, you can see it there. This is then put in the centrifuge. Here it is. They separate the serum from the cells. Then the serum is what is used in the laboratory. So these are all machines that are dedicated for specific analysis. Like this one does beta HCG, which can be used as a cancer marker for a certain cancer called choriocarcinoma. The same thing with pap smear. So majority of the cancers we are able to screen or diagnose when there is no symptoms or there are no lumps and bumps. So that's very important to emphasize.
I think what I can add is we know that universal health coverage is a reality in our country. It's coming. So what we'll want to urge, one, to tell the public is a good thing, because every member actually health is a right. So every Kenyan, whichever corner of the country they are at, they should be able to access quality health care. But as the term sometimes you find is being used interchangeably, whether it's universal health coverage or universal health care. Because you can just rush to have coverage, but if you don't have quality, the coverage might be detrimental. You can have everyone wherever but you find everyone just doing their own thing without quality. So what I would want to urge the policymakers and our government is to think closely about integrating pathology laboratory services in the provision of a universal health care. Because as I mentioned and repeat again, and I keep on repeating, pathology is a science behind medicine. If an 81-year-old lady in Lodwar cannot access a good simple test like a blood sugar test, they can go to an hospital. No one might pick that they have diabetes, and that diabetes can kill them. If a young child, maybe 2 months old in Busia, if there is no good lab test there to be able to diagnose that this child has malaria, We can have all the big machine and everything, but we'll not be able to save the life of that child. So that's one thing we need to do. And of course, sometimes I'm now speaking as the Secretary General of Surgeon of Kenya, Surgeon of Pathologists. We've seen the national government equip hospitals with theater machines, dialysis machines, radiology machines, but we are yet to see laboratory machines being financed and rolled to the counties. I understand it might be now the next coming phase, but it should have been thought of early enough. And we urge the stakeholders to inform us, because we are the ones who can advise free of charge, because this is our country, on them, which machine they need to start with, and the ones who can have a big impact, affordable in the village, there in a health center. A blood sugar machine, most of our health centers don't have those machines, and our patients are really suffering, yes.
From that discussion of making the correct and accurate diagnosis of cancer, we move on to treatment. And treatment in this case can either be to cure the cancer or to manage the cancer and make life bearable and manageable for the cancer patient. I leave you with a sneak preview of what is coming next on Health Digest on this series of cancer. I've been your host, Dr. Mercy Korir.
I had a lump and I went to hospital. I assured the doctor that lump. He touched and told me, Grace, this is fat.
And then after asking him what was the problem, daktari akaniambia, it is less than just a small problem. And sometimes when you reach 40 and above, usually those problems are there.
But then I said, if it is healing me, let it be.
Nisema daktari anatibu, ni mponyaji ni Mungu.
Me? Cancer? No.